All right, so we have a few minutes left for questions. So we have our roving microphones. So who would like to answer the first question? We can have the lights on, I think. Yep. Dr. Miller?
Hi there. My question is kind of a general question to those of you who are primarily relying or heavily relying on things like internet and digital-based recruitment methods. I think that was highlighted in a couple different presentations. How do you plan to address the potential selection bias that methodology introduces into this research as a whole and prevent further marginalization of individuals who may not have access to internet, smartphones, digital capabilities, whether that's because of low socioeconomic resources, living in a rural community where there may be lack of broadband, et cetera?
Consuelo,
I'll
Jonathan.
start. Yeah, so there are a couple of things to keep in mind. So first, we need to recognize that low socioeconomic resources doesn't automatically translate into no internet access. The digital divide is not quite the way that we often imagine it. So it's individuals who are, have fewer resources tend to access the internet through smartphones. And we just need to make sure that if we are using digital assessment tools, that they are mobile friendly. So that, I think, is the first thing that you want to make sure of. The second thing is for my Forever study, we actually did, we're doing a combination of sort of online survey-based recruitment along with complemented, like on-the-ground kind of door knocking and in-person recruitment in Harris County, Texas. So we do have some planned analyses to compare sort of the representativeness, which I think is really important. We talk a lot about diversity, but we don't have a denominator. And so we want to compare those groups to one another to see which one of those groups are more or less representative in terms of how generalizable it is to a specified catchment area, and whether there are groups that are left relatively invisible. So that said, there are some groups that are not really well captured by either method, particularly individuals who are unhoused. And so my particular study actually has an unhoused recruitment component, which will also be one additional component of kind of comparison. So, the bottom line is that, we often talk about inclusion, but we don't yet have like a great method of recruiting or including everyone. But I think that there are still some questions that have not yet been resolved in terms of what that means in terms of generalizability to our data and in terms of our ability to effectively recruit or at least expect kind of an isomorphic result of recruitment practices across these groups. So there are a lot of scientific questions that I think are embedded in your question that we have not yet resolved, but I am hoping that my study will at least give us some indication about them.
Did anyone else want to respond?
I'll just chime in briefly and agree with Dr. Jackson that often we're implementing a multimodal strategy, so we're trying to recruit in different ways. But I would also suggest that we often presume that there's a digital divide when in actuality many people, regardless of their educational attainment, are very savvy with their devices and can do many things on them. They just aren't doing the things that we think we want them to do, or they're not interested in those things. And so we have done our community engagement studios with individuals from these backgrounds, including individuals living in rural communities, to try and understand what it is that they would like, how they would like to be connected. And again, I would encourage everyone to just not presume that people cannot access versus they don't want to. They don't find us trustworthy enough to be engaging in things like clinical research via their mobile devices.
Okay, great. We have a question over here.
Good afternoon. My name is Glenda Wright from Rutgers University. I am just amazed or at awe of the big divide there is in research participation among African Americans. I had no idea the research is so vast. My thing is that we have to dispel the rumor that a lot of African Americans are they don't participate. A lot of them do participate. And like Dr. Wilkins had said, there's no more excuses. We don't have a lot of the excuses of the Tuskegee experiment or, you know, different experiments. We don't have those excuses. I think that the approach in which you go into a community, that is the problem. So therefore, if, you know, that's what I was going to, you know, want the panel to, you know, to help me to understand why there is such a big divide in this research. And it's not because of unwilling participants.
Okay, Darrell?
So I'll start out. Can everyone hear me okay? I think that, so people think about Tuskegee, oftentimes when I talk to people in the community, a lot of people don't even know the particulars of Tuskegee. Oh, sorry. Can you hear me better now? Okay. So to answer the question, I'll take a first attempt. Now I'll look to my panelists, my fellow panelists, to offer other insights. Oftentimes when I talk to people in the community about research participation, a lot of folks have never even thought about, some people have never even heard of Tuskegee, let alone Henrietta Lacks or other types of, say, violations of ethical research conduct and other types of violations in general in terms of trust. But I think that every community has their own Tuskegee. They have things that have happened in these communities that people, it almost sounds like a myth to some folks, but people come in and they talk about things that happen in Barnes-Jewish Hospital. They talk about things that happen at Homer G. Phillips, which is here in St. Louis. And these are things that oftentimes, even if it's not these big national cases, there's still things that are happening at the local level that people have to contend with. So I think that in combination with just general mistrust, for good reason, I think that sometimes people are skeptical of folks coming in, no matter what you look like. So my grandmother always taught me, all skin folk ain't kinfolk. And so just because you have a representative person does not mean that you're going to gain automatic entry with a silver platter in certain communities, because people have been, you think about Tuskegee, there was a black nurse who led recruitment efforts there. So people are aware of these things. So again, I think the local level to me is important to, not just from a national perspective, but also to think about what's happening at the local level and why people might be reticent.
I can add something really quick, and I think one of the things we forget is even though we are recruiting individuals into AD studies, there are multiple other studies that are going on at the same time. Cancer research, there's, I also worked with prostate cancer research in Indianapolis, and at any state in time, if individuals who go out to recruit do the helicopter recruitment, those individuals that are left without data or information as to what happened for that specific recruitment effort, they talk to each other. And so it's not a matter of people not wanting to be a part of these trials, but these concurrent practices of going into neighborhoods, the same neighborhoods at that matter, to get these individuals to come into various different trials, they add up. And over the course of years, individuals get wise up to the fact, oh, you're coming again. I remember what happened in so time, or there's a rumor that this happened before. So it's not that we realize that African Americans or Latinx communities want to be a part of this. The problem is these stories happen, they keep happening, and as a result, people create these images of what they think is going to happen, and they stay away. So
I'll just add, I think maybe the unspoken so far issue is the lack of accountability. So we're more than 25 years out since the NIH has required that we have diversity in our clinical trials. but who is holding all the NIH investigators accountable for their enrollment tables that they submit that say they're going to have a specific amount of diversity, and they don't achieve it, and they still get funded, and they publish the papers, and the editors and the publishers don't require that they justify why there's not diversity, and there's the FDA approves the drugs that Dr. Jackson just showed us with limited, very few people, again, from the populations who are experiencing disparities in that study, in that sample. No one is being held accountable. And so until we have people who are holding us accountable for this work, we will continue to struggle and act like this is incredibly hard when most of the people in this room know how to do recruitment. But no one is requiring that we have budgets, resources, and teams who are qualified and adequate to do the work.
I'm gonna.
Raina? Raina?
I want to, Monica Parker from Emory Goizueta Alzheimer's Disease Research Center. And I want to follow up on something that Dr. Jackson talked about. He said that 3 key indicators or for gaining some support for African American participants were 1, their contact with their health provider, secondary community events, and 3, social media. Everybody has talked around the issues of awareness, but I have yet to hear anybody talk about how they're actually engaging medical professionals who are seeing these people. In the work that we do, people of color, and I'm going to leave it at that, may not be engaged in research because the providers that they see don't know about how to get them engaged in that research. How are you getting health providers into the awareness and recruitment process? And the second part of that question is, how are we educating our teams? Because this has been great presentations, great information. I just don't think that everybody in all of our centers is on the same team.
Amen to that last point. We are not all on the same team, but I will say, again, from my study, everybody's claiming credit. Everybody's claiming credit for the work that's being disproportionately borne by women and by Black women in particular. So I just want to let's give a round of applause for the women who are doing this work, and just give them just one moment of recognition, independent of us men. Just one moment. Now, to answer the first part of your question. There is a larger theoretical concept that I didn't have time to include in my already overstuffed talk, and it's just an expansion on Dr. Wilkins' concept of return of value. So if we think about return of value, the way that we commonly apply it is to research participants, but it also applies to each and every stakeholder, each and every kind of individual that is involved in the larger conception of completion of a research project. So we need to build in return of value at the provider level. And so we need to make sure that we understand what that looks like. So if you are trying to reach out to, say, primary care, and you want those individuals on your team, so primary care that are at federally qualified health centers, FQHCs, you need to build in a clear, multi-level return of value at the level of the institution and at the level of the individual provider. Now, this was outside of my talk because it's another study that I'm doing, but we're actually doing this in Boston. So I'd love to talk to you about how exactly we're doing that. So what we are doing is we are building research infrastructure for a couple of FQHCs in Boston to conduct their own high-quality neuroimaging and neuroadjacent research. We are also helping support them running a trial where they got a funding from I think the CDC to do a study on cardiovascular health. We are helping them conduct that trial. We are providing personnel for them to conduct clinical research, and we are also providing individual support for providers in diagnosing and managing dementia that presents at the FQHC, as well as helping the FQHC deliver a community-oriented campaign to build literacy around research and around cerebral and cardiovascular health. So if you do those things, then you are much more likely to be able to get 6 seconds, like during a patient visit, for somebody to say, here's a flyer, these people are really good, go talk to them. Or better yet, you can embed somebody within these clinics to kind of help pass along that message. You can really have the benefit of that warm handoff. You can bring in co-investigators. You can offer co-authorships. You can create sub-awards and make sure that that there are research dollars that are flowing into these places. You can give them administrative support as you're navigating all of these things. So you really have to build in those multiple returns of value at the provider and the institutional level to make sure that they are effective, that they are true partners in advancing your message to try to either recruit people or try to intervene on disparities.
Great. We have a question online.
Yes, we have a question from Dr. Nina Silverberg with the NIH, and her question is for Mr. Coker. She asks that now that you are successful in bringing in more underrepresented participants into ADNI, what are the plans to improve inclusion for those groups in autopsy consent and success?
Godfrey, that's you.
Well, first and foremost, I wanted to make sure everybody understand that my role in ADNI has been very specific, and that is to ensure that individuals who are in underrepresented groups show up in a larger scale. When it comes to that specifically, we are still trying to understand the reasons why, the multifaceted reasons why people have declined in the past to be a part of that. And what we're realizing is there's a lot of, it's like an onion peel. As you go through, you find out that there are faith-based reasons. There are other reasons that pertain to families having to make decisions for individuals, and those individuals not trusting the system as we see going forward. But we have created advertising paraphernalia, and also what I mentioned at the end, making sure it's parallel to the boots on the ground way where people are understanding the procedure for these things to happen, but have people in front of them to see that this is not just a one-sided, hey, we're sending you some information, say yes to it. No, there has to be a digital effort, but also concurrently you have to have people who are boots on the ground and can talk to individuals about why this is necessary. So those decisions are still being made as to what's appropriate and what's not, but we are in process, and I think that's how I wanted to land this answer for you. Hopefully that helps.
So last question, Dr. Croft.
Hi, I'm Raina Croft from Oregon Health and Science University, and I'm hearing a lot about the countless hours it takes necessarily to be in the community to reach communities of color, underrepresented minorities, right? But I'm also hearing that that's unpaid. And I have a problem with that because the majority of us doing the work are also from underrepresented communities. And we talk about representation, we need to increase, yet how are we gonna get our institutions and our ADRCs to really pay for that time, or to pay for more people to spread out that work? Because what happens is we become burnt out, and then we got a new wave of people, and we've got to start rebuilding those relationships. So how are we going to address the time or the adequate pay for all of that outreach?
So maybe
that our colleagues many times don't have to do on the weekends.
Maybe that's a question that should. Maybe that's a question that could go back to the National Institute on Aging and Dr. Silverberg, because I think it's a very important point. Listen, we're over time. If you have questions that you didn't have a chance to ask, come on down and talk to our panelists. What's that? They're coming down, and everyone else is going to lunch, but yes. You guys get lunch first. So go. Junior investigators, come on down. Give our panelists a big round of applause.